Thank you, and I would like to thank the organizers CNS and partners for inviting me to present on HIV, hepatitis, STIs, and TB overall and an overview in the WHO Southeast Asia region. We are 54 months left to the SDGs 2030, and this is about how we will connect the dots and moving forward. So a bit about the WHO Southeast Asia regional burden of hepatitis, HIV, STIs, and TB. We are a region of almost 2 billion people with 10 countries. And in the WHO SEARO region, we are around 14% of the global burden of people living with HIV, people living with hepatitis B and hepatitis C. There is 8% of the global burden of people living with HIV, including children living with HIV. And the region has 16%, around 60 million new infections of the 4 curable STIs, consisting of chlamydia, gonorrhea, trichomoniasis, and syphilis. As you can see, the epidemic impact consists of new infections and death, but also infections among very special population groups, including pregnant women and children. We have still 8,000 cases of congenital syphilis, still 3.5 years from the SDGs. Globally, the Southeast Asia region, including India, has very high substantial burden of TB cases. The region is around 40% of the TB cases and global TB deaths. Almost half of all TB households have catastrophic expenses. But the good thing is that the region fares well in terms of TB case notification and in treatment success. So in the WHO Southeast Asia region, we have and are guided by the Integrated Regional Action Plan for Hepatitis, HIV, and STIs. So in the last year or so, we had a midterm review that showed that there is major policy shifts and political commitment, including many new or updated national strategic plans done in the last several years. And however, there is still challenges in financing these plans and getting refinements of program implementation. There is proof that triple elimination is achievable in the region because we have now 3 countries that have either dual or triple elimination. And integrated multi-disease elimination is feasible with practical service approaches. So over here, our experience of triple elimination of HIV, syphilis, and hepatitis B is that countries can achieve it, but we in this region will need large countries which have large populations to champion and continue to accelerate with subnational approaches. So last year in October, we celebrated Maldives being the first country globally to have achieved triple elimination of HIV, syphilis, and hepatitis B. And Thailand and Sri Lanka are currently working towards the 3rd elimination based on their experience of having achieved dual EMTCT of HIV and syphilis. So we continue to have progress in different countries. For example, in India, HIV, syphilis, elimination of vertical transmission was started in 2023, piloted, and then was subsequently expanded all over the nation in 2025. And in 2026, the government established the National Validation Committee for Triple Elimination. Thailand and Sri Lanka are both working towards the hepatitis B elimination of mother-to-child transmission. And very importantly, that modeling estimates have shown Bhutan and Thailand having achieved the 2030 goals already of hepatitis B elimination. However, validation would be an important next step. In the region, AIDS is not over. SEARO is experiencing a stagnating epidemic in progress. We have better 95, 95, 95 cascades with the latest data out this year. However, we are challenged by having 2 out of 10 SEARO countries having treatment coverage less than 50%. Late diagnosis with low CD4 count continues to drive avoidable illnesses and death. And the SEARO region retains a large epidemic with expanding epidemics in 4 countries. Nearly a quarter of people living with HIV are still not receiving life-saving treatment. So over here, you can see in this table that Thailand is on track, but the rest of the other countries have progressed, but not quite yet on track. And very importantly, every hour, 3 young people are getting infected. These are young people between more than 15 years to less than 25 years old. And these are the future generations that are still getting infected with HIV. HIV prevention is still at the critical inflection point. Key populations are not reached with effective and adequate prevention services, including pre-exposure prophylaxis. And over here in this first graph, showing different countries in the Asia-Pacific region, we bear lessons learned from Fiji and Philippines, which are seeing substantial new HIV infections. So, but we have also in PrEP coverage a relative 98% gap in 2025. However, there is optimism in the region because by 2027, there are potential game-changing HIV PrEP long-acting injectables that cost $40 per person per year, which are Indian generics which are slated to come into market. Turning on to hepatitis elimination by 2030, because this week we celebrate the World Hepatitis Day, 28th July. So in hepatitis elimination, the region is not on track. There is uneven progress across the region. Some countries are faring better, but some countries still have yet to initiate, to establish, and to consolidate gains. Overall, hepatitis B birth dose is less than 90%, although over here you can see that the pentavalent is pretty good. There are 6 countries that have been verified for hepatitis B control goal through vaccination of less than 1% hepatitis B surface antigen, seroprevalence among children over 5 years of age. And we can see also that we fare not well in testing and treatment of people living with hepatitis B and C. Although SEARO does have one of the lowest benchmark pricing for both hepatitis B, tenofovir, entecavir, as well as the hepatitis C DAA drugs. Liver cirrhosis and cancer are projected to increase due to hepatitis B and C beyond 2030. And overall, because we have very inadequate surveillance systems around hepatitis, there is inadequate data on the cascades coverage of hepatitis B, prevention of mother-to-child transmission during pregnancy, and also a concurrent issue of hepatitis C infection in pregnancy, especially in humanitarian and in fragile settings. In turning on to sexually transmitted infections, there are challenges and opportunities. I would like to remind everyone that there are more than 30 different bacteria, viruses, and parasites known to be transmitted through sexual contact, including vaginal, anal, and oral sex. So we know of the usual STI causing pathogens, but very importantly, Mpox is endemic in several countries now, as well as there is a Zika virus that also is passed through sexual contact and causes microcephaly based on data from several countries. And over here, you can see the table for coverage of syphilis testing in pregnant women, where we have the most data in syphilis in pregnant women and congenital syphilis. So there is a high burden and an opportunity to improve services for STIs. But what we require to do is to strengthen STI surveillance, improve STI drug resistance, especially gonorrhea drug resistance. And we are very concerned around syphilis increase reported in several countries, and especially among young people less than 25 years of age. But the overall messaging around STI is that elimination of congenital syphilis by 2030 is feasible, and it can be done through triple elimination and improving the maternal child health services. I would like to call everyone to a call to action, because elimination in the next 54 months is possible. Elimination as a public health threat means combining all existing interventions at scale. And that's where we really talk about coverage. So it spans from hepatitis B immunization to specific intervention for prevention of mother-to-child transmission, for HIV, for syphilis, hepatitis B and C, treatment, to accelerating the adoption of quality assured diagnostics and multiplex tests, which are also going to come into market. We have to improve the choices for HIV prevention through PrEP, both oral and injectable. And we have an exciting tools that are coming in the next several years. Very importantly, we have not to forget good harm reduction services for people who inject drugs. And this is the area that is often lagging behind in most countries in the region. So coming to TB, we know what is working. We know that these persistent challenges. We have a lot of the tools. We have the expertise. We have AI and digital health. And most importantly, delivery and engagement and provision of services by communities, affected communities. And this is what works. But really importantly for TB is, what can we do more? We can accelerate, we can improve, we can expand active case finding, prevent through TPT, and diversify the groups, embed in convergence and integration of service delivery, and most important, to reinforce multi-sectoral governance and public-private partnerships. And very importantly in this region is begin vaccine preparedness, because it is coming. So for the region, what is important is adapting to the new funding environment. We have a long list of things to do, but the good thing is that we have the tools, we have expertise, we have the experience of elimination, and we have collaboration and partnerships, including looping in public-private partnership and very successful, highly effective community-led services. So we know all these things work. And how can we move forward? We should also, in this new funding environment, when we ask to say, do more with less, I say we can do more with doing differently. And what is that differently? It is optimizing partnerships, leveraging each other's strength and investments, and together moving forward. Thank you.